There are a number of issues to be considered when initially scheduling your patient. If you can establish these ahead of time and set up defined protocols for your scheduling staff and technologists, this can go a long way to making your life as the lead physician easier. When I first began our program, I spent a great deal of my time with phone interruptions, determining which patients should be scheduled and when that scheduling might be appropriate. The first issue to consider is who should do the scheduling. In our hospital system, all of the scheduling for radiology exams is performed with a centralized scheduling department. The system is sufficient for most imaging studies in our department, but we found it significantly problematic in scheduling our breast MRI patients. There are a number of factors which need to be considered when scheduling a breast MRI. We found it impossible to have standardization of these criteria in a scheduling department where a different staff member may be scheduling on any given day and where there might even be turnover in personnel. For this reason, we found it beneficial to have our central scheduling department contact our breast MRI technologists at the time of scheduling an exam. In this way, our technologists are able to assure that the appropriate screening questions are addressed, such as the phase of the menstrual cycle, is the patient postmenopausal or on hormone replacement therapy, as well as what are the indications for breast MRI. They have become very familiar with the indications for breast MRI, as well as appropriate timing for scheduling and also with the exceptions that arise to our standardized rules. We initially began funneling the scheduling of our exams through our lead technologist, but then this was expanded as additional technologists were trained. We have found this system to be much more effective in guaranteeing appropriate scheduling of our breast MRI patients. When unique circumstances are presented, the technologists know at that time to consult with the radiologist in making final determinations. Failing to have a specialized means of scheduling significantly increases the chance of both performing inappropriate breast MRI exams as well as being put in the position of imaging patients at an inappropriate time of their cycle or in other situations which can often lead to suboptimal imaging results. Now, assuming you do have a patient who has been screened for an adequate indication for breast MRI imaging, what are some of the screening criteria we utilize for scheduling? First, it needs to be established if the patient is pre- or postmenopausal. In our standard evaluation of premenopausal patients, we will insist on scheduling on days 7 to 20 of their menstrual cycle, although we do preferentially schedule during days 7 to 14 of the cycle. In doing this, it avoids the luteal phase of the menstrual cycle, where there is commonly an increased degree of enhancement diffusely of the normal fibroglandular tissue. As we will demonstrate many times throughout this course, as well as within the teaching files, this can significantly limit your evaluation, particularly for more subtle disease. This tends to be most pronounced in the week prior to the onset of menses. We generally allow 1 week after the onset of menses for resolution of these hormone effects. With our high-risk screening population, we are even more stringent, insisting on day 7 to 10 of the menstrual cycle. When these patients are called and scheduled for evaluation, the exam is discussed with the patient, and the patient is advised to call our department with the onset of their next menses, and we will schedule the exam at that time. If the patient is on birth control pills or patches, we will schedule them on day 7 to 10 of their pill-induced cycle. We have, however, seen instances where, despite these restrictions, there is still significant enhancement of the parenchyma with patient on birth control pills. At the time of their exam, we do discuss this possibility with them and the remote possibility that we may, in rare instances, need to consider repeat imaging off birth control pills or patches. We discuss this with them so they will not be alarmed in the event we feel this is necessary. Some patients are on alternative hormone therapy such as Depo-Provera, where they may not have normal cycles. We merely proceed and schedule these patients in our next available slot and note this on the patient's information sheets so that the radiologist is aware of this issue at the time of image interpretation. In our postmenopausal patients, we will schedule them in our next available slot unless they are on hormone replacement therapy. In these instances, we strongly recommend discontinuing hormone replacement therapy for 30 days prior to scheduling. In women who are recently postpartum and breastfeeding, we will attempt to delay imaging for at least 3 months, after cessation of breastfeeding. There has been literature, however, demonstrating that invasive cancer is still detectable by MRI during breastfeeding. Obviously, if there is a palpable mass or strong suspicion of disease, we will proceed immediately with MRI imaging. We are fairly stringent with our scheduling criteria relating to variations in hormone effect on the breast parenchyma because we have seen firsthand how hormonal effect can significantly hinder interpretation of the exam. As breast MRIs are a costly exam and as they are often the final study in a long chain of preliminary exams, they are often associated with a high degree of anxiety on the patient's part. As a result, we make every effort possible to have our exams performed in the most optimal manner the first time they are performed so that we can render a definitive diagnosis and avoid as many equivocal readings or repeat exams as possible. At the time of scheduling, information as to the patient's most recent mammographic and/or ultrasound exam should be made. These must be available at the time of the MRI interpretation, and if they are performed at an outside institution, please instruct the patient to bring them with them. If the patient has not had a mammogram within 1 year, our technologist will generally not schedule the exam until the situation has been discussed with one of the radiologists. Now, obviously, there are exceptions to these above scheduling criteria. First and foremost are those patients who have recent biopsy-proven breast cancer or who are by physical exam or mammography strongly suspected to have breast cancer. We will not make these patients wait to schedule their exams. Generally, these patients are being referred from breast surgeons who have become familiar with the potential for a slight decrease in sensitivity of the exam if hormonal influence is prevalent. In conclusion, when beginning your breast MRI program, be sure to establish a defined approach to scheduling your patient to assure that appropriate patients are imaged and, when possible, at the most optimal phase of their menstrual cycle. This, in turn, will improve the quality of the final exam and interpretation.